Hello, everyone. Welcome to Crohn's and Colitis Canada's webinar on COVID-19 and inflammatory bowel disease. If you experience any technical problems during the webinar, please try refreshing the page or your browser. You can also comment in the questions box in the menu on the right side of your screen, or email learn@crohnsandcolitis.ca. This webinar tonight is recorded. A link to the video will be sent to you and posted to our website 24 hours after the webinar takes place. French subtitles for the video will be available the following week. You can access all of our webinar videos at www.crohnsandcolitis.ca/webinars/videos. Our question and answer session today will be a combination of answering questions that were submitted live during the session tonight, as well as questions that were submitted ahead of time in the registration form that you completed or the survey from last week's webinar. Before we get started, we'll quickly run through some webinar logistics. If you're having trouble hearing the webinar, it could be one of a few problems. The volume of your speakers might be too low. Try turning up the volume gradually until you can hear something. It might be also playing through a headset. If you have a headset plugged in, it might be using it as your audio output instead of your speakers. Either use your headset or unplug it. You might not have any speakers plugged into your computer or device. Check to make sure, and if it's not working, try going into your settings speakers on your device. If you're using a computer and the wrong audio output device is selected, again, go into your speaker settings and try selecting a different device output. After you test your speakers, if you still are having problems, please use the questions field on the right-hand side of the screen or email learn@crohnsandcolitis.ca and we'll do our best to help you. And now I'd like to introduce Crohn's and Colitis Canada's President and CEO, Meena Mawani. Thank you.
Thank you, Sarah. Hi, everyone, and welcome to our webinar. Thank you for joining us today. Crohn's and Colitis Canada is bringing you world-renowned IBD experts to answer COVID-19 questions that are on your mind. Today, we're going to shake it up a little bit and have a live Q&A. As you all know, our promise is to cure Crohn's disease and ulcerative colitis and improve the lives of children and adults affected by these chronic diseases. We're here to support the IBD community across Canada. We know that you need us now more than ever. We're here to deliver credible information and tools and navigate you through this crisis. So here's what we've done. The COVID-19 section on our website is updated each week in English and French, factoring in the guidance from our COVID-19 IBD task force. Our webinars are recorded and available for replay on our website. We are actively promoting new content on social media and by email and hosting live online wellness events like yoga and mindfulness sessions. So while this pandemic affects us today, the work that we do to advance research and programs is long-lasting, like our AbbVie IBD scholarship. So while school may seem very far away now, I thought I would take a minute to highlight that our IBD scholarship is now accepting applications. 10 post-secondary education scholarships of up to $5,000 each will be awarded to students across Canada. Our deadline for applications is June 1st, 2020, and you can apply at ibdscholarship.ca. Our 25th anniversary Gutsy Walk is also an initiative that is dear and close to our heart. At the heart of Crohn's and Colitis Canada, we're committed to the health and safety of our community. And so we've postponed our Gutsy Walk from Sunday, June 7th to Sunday, August 23rd. Our walk this time will be a virtual walk. It's our 25th anniversary, so we want to make this walk truly special. A virtual Gutsy Walk allows you to participate from any location and in your own way. Please register at gutsywalk.ca. Finally, Crohn's and Colitis Canada has convened a superstar task force, a COVID-19 IBD task force, which is comprised of adult and pediatric GIs and nurses, infectious diseases, public health, IBD, and mental health experts, as well as a patient advocate. So here's a peek at our task force, who meets every Tuesday to discuss policies and recommendations necessary for our community. Dr. Gil Kaplan, Dr. Eric Benchimol, Usha Chauhan, Dr. John Eric Gia, Dr. Deanna Gibson, Dr. Ann Griffiths, Dr. Simon Hirota, Dr. Jennifer Jones, Dr. Rina Khanna, Dr. David Mack, Dr. Laura Targovnik, Dr. Lisa Barrett, Dr. Mark Burdett, Dr. Charles Bernstein, Dr. Cheryl Fowler, Dr. Peter Lakatos, Dr. John Marshall, Dr. Remo Panaccioni, and Ms. Sandra Zielinski. I want to thank these folks so very much for the incredible work that they've been doing. With their expertise, you're able to get your questions answered. I'd like to now introduce you to the host of this webinar, Dr. Gil Kaplan, who is a professor of medicine at the University of Calgary. He's an adult gastroenterologist and epidemiologist. He's our chair of the Scientific Medical Advisory Council, as well as he sits on the Crohn's and Colitis Canada Board of Directors. Dr. Eric Benchimol is an associate professor and gastroenterologist at the Department of Pediatrics and School of Epidemiology and Public Health at the University of Ottawa, Division of Gastroenterology at Children's Hospital of Eastern Ontario. And he is also the chair-elect of the Scientific Medical Advisory Council. Thank you to Dr. Gil Kaplan and Dr. Eric Benchimol, and welcome.
Thank you, Mia. So probably everyone's noticed I'm not dressed as nice as I usually am for these webinars. I'm in my scrubs, and that's because this week I've been on call at the Foothills Hospital here in Calgary. And it's given me the opportunity to actually be in the front lines of the COVID battle and to see my colleagues who are physicians, my colleagues who are nurses, pharmacists, the lab techs, the cleaning crew, to see everything that they're doing to prepare for this pandemic and to start to take care of patients who are currently in our hospitals with COVID, and as well as taking care of people who are in hospital for all other reasons that can't pause because of COVID. And despite being on call and being a very busy week, this webinar every Thursday night, this is something that we want to be here and do it kind of no matter what the case may be. This is our third series, and I'm going to be giving another presentation on the epidemiology and giving some updates where things are at. And then Eric, if you want to talk a little bit about kind of what you're going to be doing and just the new format that we have for today's webinar.
Absolutely, Gil, and I'm actually on call as well at CHEO in Ottawa, but I changed first. I had to get out of the scrubs. But so a little bit of a different format. So the update on COVID to begin with Gil, and then an update on the guidelines, any changes that we made this week, and there have been a few changes, small changes. And then we're going to launch straight into a Q&A session where we're going to be answering people's questions live, as well as some questions that were submitted at the time of last seminar when we asked for a survey afterwards, as well as when you registered. So we'll try to answer as many questions as we can. If you have questions, you'll be able to type them into the chat box, to the question box that you have on the right-hand side of your screen if you've got GoToMeeting up on the right. And we will try to answer them as best as we can. A reminder that we cannot provide personal health advice. So if you ask us about something that relates to your health or the health of a family member, unfortunately, we will not be able to provide it. So please try to keep it general, try to keep it for the entire audience and not just about your health, because legally we just can't provide personal health advice at this webinar. And any advice that we provide really should be discussed with your physician. This is not considered personal health advice for you. Please discuss it with your physician and your healthcare providers, your nurse and your team, and don't take this as personal health advice for you.
Yeah, and the only thing I would add, Eric, is that this is changing so rapidly. This was something we didn't even know about in December, and we've just in the last few months learned a tremendous amount of information. And you'll see even the information I'm going to be sharing with you on our presentation is changed dramatically from week to week. As we gain more knowledge, this advice will change and be dynamic. And that's why we want you to be here with us every week for these webinars. So again, I just always like to start with a bit of just terminology to frame the discussion. The reason being is that some people are new and others may forget. And just to remind everybody that coronaviruses are a family of viruses. They cause a number of different infections, from the common cold to severe infections like SARS. The virus that causes COVID-19 is called SARS-CoV-2. Again, previously never been heard of before. It's something that we have no immunity to. We have no antiviral agents for it. We don't have a vaccine. And that's why it's such a serious and deadly virus. The disease that it causes is called coronavirus disease 2019 or COVID-19. And we're starting to learn actually there's a lot of different symptoms that people are manifesting, but predominantly they are pulmonary symptoms like fever and cough. So I just wanted to start today with a bit of a history lesson as we're starting to reflect back on this pandemic and trying to see, you know, when was the last time we had something that looked like what we're dealing with right now? And I think people are starting to come together to realize that this is analogous, comparable to the 1918 pandemic that went throughout the world. And I just wanted to share this slide, and it's actually a really good article to read in detail from National Geographic. They talked a little bit about the different responses that happened in different cities in the US in 1918. And what these graphs are all going to show are deaths per 100,000. So how many people died from this infection relative to 100,000 people living in a particular city. And we can see here that Philadelphia was hit very hard. And one of the reasons that they hit hard was explained here is that they waited 8 days after their death rate but began to take off. So 8 days after this point, before they started to do the physical distance measures that you're seeing happen across Canada. And so what ended up happening is they had a spike, overwhelmed their healthcare system, and then eventually leveled off quickly. Compare that to New York City, which had amongst the lowest rates that were seen throughout the United States. And again, what they did is they started their quarantine very early, 11 days before this spike in deaths. And then they were able to maintain those restrictions for quite a long time to eventually kind of let things level off. A lot of the questions, and I'm sure we'll get into these in the question and answer period, is, you know, how long is this going to last for, and when should we start to relax these social restrictions? Well, we have some indications for historically what happened, and here's what happened in San Francisco, where they were able to have initially a short peak in death from the disease, but then relaxed their social distancing efforts and resulted in a second wave. And then you can compare that to St. Louis that did this at a much more strict case, kept things flat, relaxed things a little bit, and then peaked again. We're right now right here. And so these next few weeks are going to be very telling to figure out what not only happens with this first wave, but also what's going to happen in subsequent waves that could potentially happen. So that brings us to a slide that you guys will probably remember if you've seen my first two webinars, and this comes from the Johns Hopkins website. The link is right here. And if you remember, this is the shot that I showed you on March 19th, 11 a.m. And at that time, there were 230,000 confirmed cases. And if you can see here, what's happened over the weeks. So on March 19th, 230,000 cases. Last week when I presented this, there was 500,000 people who were confirmed. And as of today at 1:30, when we took this shot, over 1 million people have been confirmed cases of COVID across the world, including 51,000 people who have passed away from the disease. So these are global trends. It's very similar to the data that I've just shown you, but looking at it linearly across time. So we can start to see back in January and bring this all the way up to April 1st, yesterday when we collected this data to present. And you can see how there was a slow rise, and then all of a sudden, as we get into mid-March, we see a spike in the global outcomes. And compare that to people who have recovered and people who have died as well. And what you can see here that's really important is that there's a lag between being infected and either recovering from it or dying. And so what we're going to start to see here is as this kind of spikes up, we're going to start to see what happens to the recovery and death curves, recognizing that we're all going to be 2 to 4 week delays. And what that means is over the next 2 to 4 weeks, we're probably going to be seeing some of the darkest times that we're going to see here in Canada in relationship to this pandemic. So what about Canada? This was the screenshot that I showed you on March 19th. At that time, there were 780 cases and 10 people had died. And you can see as we go 1 week later, on March 26th at 1 o'clock, when I did this presentation a week ago, the cases had jumped to 3,400 people, of which 35 people had died. And as of today, there's 11,000 Canadians who are confirmed positive for COVID, 130 deaths. And importantly, you can see this 4,000 number reflects the number of cases just in the past 4 days. So you can see that this is going up quite fast. And this is reflected in these videos. And I want to pause and give Joseph Windsor credit for creating these slides. I've been very busy this past week, and I have this amazing team, including Joey, who's my postdoc, who put together these videos to compile this data. And I think you're going to see here, this is actually, I think, a brilliant way to look at what's happened in Canada. And you can kind of look at which province you are and see between February 2nd all the way up to mid-March to April 1st, what's happened in terms of the number of people who've been affected by COVID across the country. And you can see how quickly things have escalated in the last few weeks. And you can see how many people have had this disease in Canada based on the provinces. You can see here. Similarly, this next video reflects the number of deaths that you can see in Canada. And you can see there are virtually no deaths at all for many, many weeks. We won't start to see this outcome climb until we get into mid-March, and then we'll start to see some of the first cases. And this reflects, again, to the point that I made earlier, that recovery and death lag about 2 to 3 to 4 weeks from the cases. So we're going to be seeing all of this evolve in the upcoming weeks, and I'll be updating these graphs and showing to you week by week what's been happening here in Canada. So what I'm going to do here, these slides are going to look similar to last week, but last week and the week before, I shared with you data from the CDC from the US, and that's because they had the most robust and up-to-date data. More recently, as we've had more cases in Canada and more time has gone by, we've actually started to get some really good Canadian data, and that's what I want to share with you. And so first, I just want to reflect to you the age distribution of COVID cases in Canada, looking at Canadian data as of the end of March. And we can see that if you're under the age of 20, only 4% of confirmed cases. Now, it doesn't mean that many kids or other people who are not confirmed have gotten sick with it. But in terms of confirmed tested cases, 4% are under the age of 20. 1/3 are between the ages of 20 and 39. 1/3 are between the age of 40 and 59. And as a 45-year-old, I fall into this category. And 1/3 is over the age of 60. And now I want to look at outcomes data stratified by age. And this is actually, I think, a good news slide. This is a serious and deadly virus. I think everyone knows and recognizes that. But when we look at Canadian data, we actually are seeing relatively good outcomes right now compared to other parts of the world. And so this is just looking at all comers, regardless of age. And 80% have mild symptoms. They can self-isolate at home. They recover. They do well. They can still serve as vectors to transmit the infection, but they do well. 14% are in hospital, 5% in the ICU. The overall death rate is 1%. If we start looking at this stratified by age, under the age of 20 in Canada, we actually see the vast majority of kids do extremely, extremely well. Only 5% ended up in hospital, and essentially none have died. As we get into the older group, the 20 to 59-year-olds, we see a higher percentage of these adults becoming hospitalized, 3% in ICU and 1% dying. And then when we go into the highest risk group, those over the age of 60, we see about 1/3 are getting hospitalized, 11% in the ICU, and the mortality or death rate is 2%. And again, and this is going to reflect later on when Eric talks about our recommendations around different ages. It's for these reasons that we recommend different outcomes for different people at ages. So again, the key to this is physical distancing. And I showed this slide again. I think I'll probably be showing this week after week, particularly as a frontline healthcare worker in the hospital. I've seen this all this past week. And again, and this is giving you some numbers from Alberta. We have about 8,500 acute care beds before this pandemic started. And if we have a huge influx in people needing to be hospitalized, we're going to have some really huge challenges. First, we're going to lack hospital beds and intensive care beds and ventilators to care for them. Very importantly, we're going to get deficiencies of protection equipment, these PPEs that are critical to protect myself, nurses, physicians, frontline workers, as we try to protect ourselves and not to transmit this infection to other patients in the hospital. Unfortunately, many of us will be exposed to this virus despite the best efforts, and will get ill. And some of us will end up needing to go home. Some of us might end up in hospital. We'll have less of us to be there to take care of people. And that means we're redeploying individuals. This week I was on call for gastroenterology. A few weeks from now, I may be covering COVID wards. And ultimately, this then impacts our ability to treat people effectively for diseases that are not COVID related, Things like heart attacks, strokes, car accidents, other things that happen. We don't want our system to be stretched and not be able to address and manage these people. So really there's two major things to do. One is we can increase capacity, and that's what we're doing. In Alberta, in cities all across the country, we are increasing the capacity of our hospital beds. That's why, for example, we're closing elective procedures, we're closing a lot of ambulatory clinics, things like that, because we're trying to free up those beds for patients who are going to be sick with COVID. We're also adding capacity into hospitals. We're also building increased facilities and going into unique areas to repurpose old decommissioned hospitals and make them effective hospitals to try to increase that capacity. And our goal, if, for example, in Alberta, is to add another 2,200 acute care beds to help us. But we recognize that even with all of our best efforts, the projections suggest that those numbers are going to go above unless we have strict physical distancing. What we really want to do is flatten this curve, is get people to be exposed to this virus, get infected, not 6 weeks from now, but 6 months from now, not 2 weeks from now, but months and months away. In 6 months from now, the knowledge that we'll have on this virus is going to expand exponentially. We'll likely have drugs that could potentially treat it, and we'll be in a healthcare system that will be able to adapt and care for you if you end up in hospital with it. So the key thing is to try the best that we can to not get infected over the next few months. So how does this work out? Again, a little bit of math for people to help understand. What's really important is this concept of the R0, which is how many people get infected with the disease if they are exposed to a virus like the coronavirus. So if you have an R0 of less than 1, that means that one individual who is sick will infect less than one person, and you'll actually see a decline in infections. Best way to get an R0 of less than 1 is to stay home if you're sick and not pass that infection on to anyone else. An R0 of 1 is stable, means one person infects one person, and the infection is stable across time. Whereas when it becomes more than 1, that's when we start to see the infection increase exponentially. So if we look at COVID, it has an R0 of 2 to 2.5. So without any physical distancing, this one individual will infect 2 to 2.5 people. And then those one individuals will then infect another 2 to 2.5 people. And what you can see over a 3 to 4 week window is that 150 people will be infected, 16 end up in hospital, and 3 end up dying. And that's based on numbers related to the global impact of COVID. If we can institute social distancing, we can bring those numbers down. And how do we do that? Well, there's 2 key things. One is physical social distancing. And the whole concept of that is to maintain distance from people. And so you want to stay home as much as possible. And if you have to leave the house, you want to be 2 meters apart from everybody so that you are not infecting them and they are not infecting you. But the most important thing is to stay home. On the flip side of that is if you do have symptoms, it is so important that you then flip to the other concept, which is quarantine or self-isolation, which is essentially keeping yourself in the house, not leaving your property so that you don't infect other people. And if we institute these measures at a population level, we can reduce the infectiveness of this disease. And that means that there are less people infected, less people in hospital, less people who die. So how are we doing? And this is modeling that Stephanie Coward, who's provided a number of the slides and has done a lot of crunching. She's an epidemiologist in our research group, and she's looking at Canadian data to see where things are going. And this is all in the concept of this whole concept of doubling time, and that is the length of time required for the number of cases to double. And you can see in Canada, if the doubling time is 5 days compared to a doubling time of 7 days. So the longer it takes for people to be infected and to that doubling time to double, it is less hospital beds, less ICU visits, less people who end up passing away from this disease. So this is where we're thinking we're going in the next couple of weeks. We want to make sure that if we do the proper physical distance, these numbers are gonna be blunted. And at the end of the day, we won't know for sure what's going to happen in Canada or other parts of the world until we go forward in time and are able to look back. And in fact, decades from now, when people look back at 2020 and are writing historical references of this year, there are going to be cities across the country that are going to have different curves that look much like we saw in 1918. And it's now going to be an opportunity to see, you know, where are we in Calgary? Where are we in Edmonton and Toronto and Ottawa and Quebec? To the things that you're doing right now to keep yourself safe, to keep yourself in home, to prevent infection and spread is really going to define what these curves are going to look like a few years down the road. And I'll end with the same slide that I'll always kind of have shown now for the third straight week. And this is whole concept of being the stationary dot. If we let society roam around here, people are going to be infected and we're going to overwhelm our healthcare system. If you are that stationary dot, if you're staying put, staying at home, preventing from getting infected, and if you do get infected, not infecting others, we're going to have a much flatter curve and all the outcomes are going to be better. And we'll know in the next month or two how well we did as a society with physical distancing. And from there, I think that leads on to what we're thinking about in terms of how we've updated and changed our recommendations through Crohn's and Colitis Canada. I'll pause there and give it to Eric to take over.
Perfect. Thank you very much, Gil. Very informative as usual. So this is an update on the recommendations that are now on the website on crohnsandcolitis.ca, dated today, April 2nd. We met Tuesday night to decide on any updates and made some more minor updates compared to previous weeks. So I'm trying to advance. Oh, there we go. So again, just to remind you of what we talk about when we talk about different definitions, self-monitoring means watch out for 14 days, monitor yourself from symptoms, and avoid crowded places and increase personal spaces from others. We should all be doing this at minimum today. Self-isolate, so if you have no symptoms and you've traveled or you have contact with somebody with COVID, stay home and monitor your symptoms for 14 days and make sure that you remain asymptomatic. Avoid contact with anybody else. You can still go out for a walk, but make sure that you're 2 meters apart from everybody else if you do so. And then isolate if you have symptoms of COVID-19 or you're diagnosed with COVID-19 or you're waiting for the test. Stay at home and avoid all contact with others. So a few changes that we've made to the pyramid from last week. Based on feedback from others, as well as the latest evidence from what we've gotten from the Public Health Agency of Canada and other sources. So we've simplified the age group for the most part. So previously, you'll remember there were different age groups depending on whether you were 60, 65, 70, and above. And we've really now just made the cutoff 65, both for a combination of simplicity reasons and because of the latest evidence regarding the risk of death and ICU admission in people 65 and above. So if you're under 65 years old and you're not taking immunosuppressive or biologic medications, and we'll define that in a second, you're really in the lowest group, but you also have to have your IBD in remission without having any moderate or severely active disease, not malnourished, and no comorbidities like respiratory, cardiac, hypertension, or diabetes. That is the lowest risk group, and we say you should be following the standard Public Health Agency of Canada guidelines of physical distancing, hand hygiene, and self-monitoring. And the QR code there for the Public Health Agency of Canada guidelines is there if you want to take a snapshot. The middle risk group are people who are under 65 years old and on immunosuppressives or biologics. And the immunosuppressives are azathioprine, 6-MP, methotrexate. The biologics are any of the anti-TNF biologics, anti-TNF being Remicade, Inflectra, Renflexis, Humira, Simponi, Stelara, the anti-IL-12/23 blocker, anti-leukocyte migration biologics, Entyvio, and the JAK inhibitors, Xeljanz. And if you're in that group, you're at a medium risk, and we recommend that you avoid in-person meetings. If possible, work at home and hold meetings with virtual technology. If that's not possible, speak to your physician about options for work and discuss options with your employer as to whether you can incorporate physical distancing in a modified duty type of scenario. And additionally, we recommend using services for vulnerable people to avoid contacts with others. So for example, grocery stores opening an hour earlier for vulnerable people, elderly, and people in this group who are immunosuppressed. Please use those services and take advantage of them. They are really there to protect you. One thing that we discussed is this third point here of modified duties if you're employed. There's a lot of question as to balancing this, the safety of patients and their families, with the need for healthcare providers. So if you're a healthcare provider, a frontline worker with this medium risk, you're immunosuppressed, but you're under 65, you have to balance the public good with your own personal safety. And we feel like it's worth a discussion with both your physician as well as with your employer as to whether there are any other options. But if you are providing care to patients or other essential services to the public, then you have to balance that with the public good. So it's worth thinking about what you're comfortable doing and what should be done. And then finally, the high risk group are people who are over 65 years old, period, end of story, or people who are under 65 and who are on corticosteroids, systemic corticosteroids like prednisone, dapsone, and others. Very important as the numbers develop. It seems like certainly being on corticosteroids puts you at increased risk for severe COVID disease and increased risk of needing an ICU and potentially dying. So you are in that group if you're on relatively high dose corticosteroids, 20 milligrams or more. Or if you have moderate to severe active inflammation, like having a new diagnosis or a recent flare of the disease, if you have moderate to severe malnutrition, or if you need parenteral nutrition, that means nutrition through a central line, through a vein. In that case, in the high-risk group, self-isolate, stay home, and consider your family also. Your family should be trying to reduce exposure to you. And what we've recommended is have a discussion with your family, and your family members should have a discussion with their employers about trying to also work from home, avoid in-person meetings, modified work duty in terms of trying to encourage physical distancing at work, and as well cleaning the residence and avoiding transmission. So trying to clean your home very well to reduce infection risk. Again, we know that this is very hard to do. We know that it's a lot of imposition on patients and their family members, but we're really trying to keep you safe with these recommendations and trying to reduce the risk that somebody's going to bring home the virus to you. So those additional considerations, so like I mentioned, if you're in an essential service like a healthcare provider, a first responder, or some other essential service, balance the public need with a higher risk of contracting COVID-19 and discuss with your local public health authority as to what they feel you should be doing. And family members, again, try to work from home if possible, avoid in-person meetings, use services for vulnerable people, and clean your residence to avoid infection. There's a QR code here for a link to CNN, which provides a very simple, straightforward way of cleaning your home and reducing the risk of infection in your home. On the website, we provided a link to a more complicated report from the CDC, also about cleaning your home, but both are equally valid. Bottom line message continues to be, please do not stop your medications. Do not discontinue your medications without discussing it with your doctor first. The danger here is that you may flare up, resulting in a hospitalization at a time when the hospitals are very stressed and where you may not be able to get the care that you should be getting if the hospitals are overwhelmed with COVID patients. In addition, a big risk is that you don't want to flare up and need steroids. Again, we don't want you starting on steroids if possible. And if you're on steroids, be aware that this may be a risk factor for severe complications of COVID, but it is uncertain at the present time. Never stop them suddenly. Speak to your physician first before stopping or tapering your steroids. However, don't start steroids on your own. If you think you're having a flare, speak to your physician first. And if you're prescribed by steroids by somebody other than your IBD provider, such as a family physician or an emergency department doctor, please speak to your gastroenterologist or IBD specialist before you start them. And remember, everything is changing very quickly, and these recommendations, again, should not replace the recommendations of your doctor, and please speak to your doctor, read or speak to your local health, public health authority as well. Okay, so with that, we're going to start into the question and answer period, and I'm going to start by introducing the panelists. So firstly, from Dalhousie University, Division of Infectious Diseases, Dr. Lisa Barrett joined us earlier in the 2 webinars ago, I guess in the very first webinar. And so she's back to provide information about COVID as a virus, infection risk, and potentially new treatments. Dr. Anne Griffiths is professor and director of the Sick Kids IBD Center in Toronto. Dr. John Marshall is a professor of medicine and Division of Gastroenterology at McMaster University. Dr. Remo Paniccioni is professor of medicine at University of Calgary at the University of Calgary IBD Center. And Dr. Dean Tripp, who was also at our webinar the first time, is Department of Psychology at Queen's University. So thank you everybody for joining us. We do have a bit of a limitation on webcams, so if you don't see everybody on the screen at the same time, it's because there's a limitation on how many webcams can be active at once. So I'm going to start with the first question from earlier in the week that was submitted prior to the webinar, and this really is a question for Lisa about what's on all our minds, and that is updates. What's the update on treatment for COVID-19, and are we going to see new treatments coming anytime soon? Oh, you are muted.
So many people would rather I stay muted sometimes.
Not us, not us.
So around the question of treatments, new treatments, as you mentioned, there's no treatment that's approved right now in Canada or anywhere else for the treatment of the lung disease or any other organ disease associated with COVID-19 at the moment. And so that's not to say there isn't therapy. Therapies include supporting breathing if people end up with difficulty breathing, fluids, and medications that will help to regulate blood pressure if they become severely ill. So I don't want people to forget that there are some therapies that can help people to make it through this and to bridge people through the worst parts of disease. And I think that's important to remember when we look back at times like the 1918 epidemics. None of those supportive efforts were there and available. So just a little pause for a moment that when we say there are no treatments, that does not mean there are no therapies. But specific COVID-19 related treatments that we know work specifically against either the virus or the immune system to help with this actual acute disease, well, there aren't any at the moment, but there are many that are being tried. Some of the more popular include some direct acting antivirals that aren't developed specifically against this particular virus, but have been used with other viruses, including Ebola or HIV or other investigational agents against other RNA viruses. Those are all in various stages of clinical trials around the world. Probably one of the more popular ones and one of the ones that has most enrollment is lopinavir ritonavir, which is an HIV medication used to inhibit the protease part of viruses. It has some activity against COVID-19 and may have some results that look promising. There's another investigational medication that isn't available outside of clinical trials in Canada called remdesivir, again, a direct-acting antiviral agent that's being developed, which seems to have good potency against the enzyme, the RNA polymerase part of the virus that makes copies of the virus. So particularly, this is being looked at in the cases of moderate and severe disease. The other agents that are being assessed fall into the broad category that many people on this call will be familiar with, including the immune modulation agents. And so we know that much of the damage done in the lungs during COVID-19 related disease is associated with fibrosis and inflammation in the lungs that happens fairly quickly, but after the first part of disease. And medications that have been attempted, I mean, there have been many around the world, but the biggest trials at the moment that are ongoing include inhibitors of interleukin-6 receptor, so to ramp down the immune system through interleukin-6 inhibition, as well as other medications like JAK kinases, which you will also maybe be familiar with as well, including ones like baricitinib. So there are many others that are in those classes that are being assessed, but the biggest trials are around those types of molecules to try and ramp down the immune system. And some combinations of those medications as well have been suggested. So those are the ones that are newest. There are trials going on that are based in both the US, Europe, and Canada, as well as China. And there are a couple of sites that are enrolling some of these trials around the country. And those would be sponsored by the drug companies, but there are also what we call investigator-initiated studies that are looking at these agents either alone or in combination for moderate and severe disease. And some people are starting to dip their toe in things like Plaquenil, a medication that's already on the market, that's available and has a long well-known side effect profile, but fairly safe, that may be used as well in earlier disease before people have severe symptoms. So that's a long-winded answer to say lots going on, but if you're not in a trial that doesn't use one of these medications, I wouldn't feel too badly. We don't actually know if they work yet, and that's why the trials are being done. So while there is some promise, including, I didn't mention the convalescent serum trial, but if anyone would like to talk about that, we can talk about it after as well. We don't know if they work. So when people come to me in a panic and say, but I must be in the trial, otherwise I'm not getting treatment, I do remind them they do get treatment. There's therapies that are available. They're just not specific, and we don't necessarily know that these work yet.
So you mentioned, just as a follow-up, you mentioned JAK kinase inhibitors. So IBD patients may be familiar with one, Xeljanz or tofacitinib. Does that mean that that drug may be safer in IBD patients who get COVID?
Yeah, good question. So inhibiting the inhibitors that are being used, or immune modulators, are not generally being tested earlier in disease when ramping up the immune response might actually be a good thing to inhibit the virus. And so it's all about timing with some of these things. You want some inflammation, some ramp up of your immune system, but maybe not as much at the beginning as you want just at the 5 to 7 day mark. And so that's where most of the trials are concentrating. So are you protected if you're already on one from getting very severe disease? We don't know the answer yet. And we certainly, to your point, there may be some risk with some of the JAK kinase inhibitors of actually developing slightly moderate disease if you're already on them beforehand. So that's a little confusing. If you're already on them, you might be more at risk of progressing, but if you only start to get a JAK kinase inhibitor later after your infection, it might be a benefit. So very, very challenging to tell at this point.
And maybe this is a good opportunity to pivot to a question from the audience. And Rima, I'm going to ask you this question. It follows what Lisa has just been talking about. And so one of the audience member asked, do you know of any cases of people on biologics who are diagnosed with COVID? Would their prognosis be worse? So kind of like Lisa was talking a little bit about Xeljanz, but what about the biologics?
Yeah, so I think that Lisa sort of touched on this a bit. I think that we need to think about a few things. Number one is, are you at increased risk for developing or being infected by the virus? And certainly, I think in patients who are immunosuppressed, we think that there is an increased risk, and that's why we have some of these recommendations that are on the CCC website. Now, certainly, when you are infected and you develop the disease, there's no real good evidence right now that you may have a more severe course. I think in general, we think that depending on the mechanism of action of the drug, that may be associated with a worse course. And I think in the last 2 webinars we've talked about sort of the secure IBD registry. And if you look within that registry and you look at the distribution of patients and their course, you know, there's really no signal within the registry that patients who are on, say, an anti-TNF therapy or some of the immunosuppressants are actually doing worse than patients that are on mesalamine. There's some slight early signals, but I think we should be very, very careful with that, with interpreting those early signals, because the numbers are still relatively small. So I think the general recommendation is that you know, if you develop the disease itself, then you should probably stop systemic immunosuppressive therapy, and then you should alter the dosing intervals of the biologics until the disease has actually run its course. But to Lisa's, you know, to Lisa's point, is one of the things that we believe may lead to more severe disease is this concept of cytokine storm, and that's why drugs like IL-6 inhibitors and or the JAK inhibitors may actually sort of temper that. So it's complicated, and again, I think if you get symptoms, the most important thing is to talk to your gastroenterologist to get some guidance around that.
As a follow-up to that, I think it's worth mentioning, maybe Anne, you can pitch in a little bit about pediatrics, because from what I understand from the Secure IBD registry, almost all the children who got COVID were on immunosuppressive medications or biologics. Can you speak to, you know, is all immunosuppression created equal? How are the children doing?
Sure. So that's the question certainly that all our patients and their families are asking. You've seen the data from Kaplan that COVID-19 illness seems to be very rare in children and teenagers anyway. So the Canadian data that Gil showed, 4% of COVID-19 illness so far has occurred in people 19 years of age and younger. So the acquisition of COVID-19 illness seems uncommon in our young patients. Now, and we don't really know why that is. Is it that they're less likely to acquire the virus, or in fact, do they acquire it but just have such a mild illness that no one really knows that it's there? We don't know that. But the question still is, if you're a young person and you're on one of these immune suppressant drugs, and I will say that in Canada right now, the most commonly used agents for children and teenagers with IBD are the anti-TNF drugs, either Remicade, Renflexis, or Humira. So it's very common for young patients with IBD to be receiving these drugs, and moreover, to actually be feeling very well on them and with their IBD well controlled. So are they more at risk either for acquiring the illness or for having something other than a mild illness if they do get it? When we've prepared our guidance, you've seen that we declared moderate risk for anyone under 65 who was on one of these drugs. And it certainly is wise to be careful. And I think we could not say that a teenager of, let's say, 14, whose Crohn's disease is very well controlled on Humira, I think we could not say that he has no additional risk. I don't think we could say that, but you do have to think, just because of the strong age-related factors, that the risk to him is less than that of a 60-year-old who is getting the same medication. We in pediatrics, just as is happening with the secure IBD registry, so we as pediatricians can participate in that, but there has also been an effort in Europe to register the occurrences of COVID-19 in children and teenagers with IBD. And you're right, Eric, that the ones that are recorded in mostly Europe so far, and it's not very numerous. I think at last record it is only 8. Now they are, I think, all on an immune suppressant drug, but on the other hand, we know that most children and teenagers who have IBD are receiving either a biologic or possibly, especially in Europe, a thiopurine alone without a biologic. So it would be a smaller proportion of children who have IBD who are just on 5-ASA, let's say. And so I think if COVID illness does occur, it's more than likely going to occur in the people who are on the immune modulator, because that's what's common, biologics or immune modulator. But the good news so far is that the illness seems to be mild, and we do think that by virtue of their young age and their good general health, good disease control, that group of patients should be at lower risk than the older adults. Not sure if anybody wants to comment on that, if you think it's likely to be true or not.
Yeah, I'll just comment. I think it's a good point that many of our patients with IBD are relatively young. And all the data we have related to COVID really show that age is the most powerful risk factor for poor prognosis. It really overrides everything else. But beyond age, the real risk factors often relate to other things like cardiovascular disease, blood pressure problems. And so, you have to go fairly far down the list before medications might make a difference. I would also point out that the early data from the Chinese experience, there are a lot of people in China with IBD, and there was a suggestion from a lot of the larger IBD centers in China that they weren't seeing infections in patients with IBD. Now, that was early days, and obviously we need more data, and we certainly don't have a lot of data yet about IBD patients outside China in Europe and in Canada. So I think we need to wait and find out, but it is a risk. I agree with you. We worry about these medications, but there are some reassuring data out there that the medications may not be as powerful a risk factor for bad outcomes as other things like age and cardiovascular disease, which thankfully don't affect many of our patients with IBD.
And John, if I could add, there's a paper that was published in Lancet about a week or so ago from a cohort of 300 patients with inflammatory bowel disease living in the Wuhan province in China, where it was the epicenter of the infection. And their physicians enacted very strict social distancing, kept essentially those individuals at home, kept regular contact with them, and they reported not a single one of them actually got COVID-19. And so I think that's a good clue to us on the most important things that we need to do, which is really just helping our patients with IBD stay at home. And actually, this kind of brings us to a question that somebody came up from the audience. Jacqueline asked, what can a nurse or a frontline health worker who has IBD and is on an immunosuppressant or a biologic do to protect themselves and advocate for themselves? So just curious what your thoughts on that and anyone else on the panel.
For me? Yeah, I think these are conversations we have all the time. There's no black and white, I think, answer to this. Every job we have in society has different levels of risk and different levels of exposure. I think we have to go back to what you presented really in terms of that inverted pyramid of risk, and know that where our IBD patient fits on that risk. Some of our IBD patients really, you could argue, have no increased risk over the general population. Others are very high risk. So the response to someone who's working in healthcare and frontline who's in that high risk category would be very different than our response to someone who's in a very low risk category. And I think that's why we emphasize in that document that there really should be a discussion both with the employer and the physician, because try to fit where you are in that spectrum of risk and where your job fits on the spectrum of exposure. But it does make sense if someone's in a medium or high risk category to do what can be done in the workplace to minimize that risk of exposure. So if there's an opportunity within your own unit of work to take on a different role that would reduce exposure, that makes sense if you're a medium risk category. We did say that, you know, we're going to enter a very challenging time in healthcare, and that's why I think Eric mentioned some of the wording there around taking other societal considerations into play. We have to be very careful that we don't take everybody out of the workforce and be overly cautious. But at the end of the day, we are advocates for IBD patients, and they're in that medium risk category, and they're in a very high risk, high patient exposure environment, for example, being a frontline nurse in the emergency room, that there may be opportunities to accommodate a role with less exposure. But at the end of the day, I think each case is different. There really should be discussion with the healthcare provider and with the employer.
Yeah, it's Remo, and I think that what John is saying is absolutely correct. I think you need a dialogue with the individual patient. I can tell you what we're doing within Alberta Health Services. If patients with IBD who are on that medium risk category, you know, we've spoken to management to try to redeploy them to other areas that would be less risky. So John gave the example of somebody who's an emergency room nurse. I mean, that nurse could be redeployed to maybe, you know, to a phone line or an advice line. Respiratory therapist probably shouldn't be working in the ICU, for example. So it's really the exposure, I think, to high or what we call hot areas, which would be the emergency department and or the ICU and or a COVID ward. And so far, at least here, again, within Alberta Health Services, you know, the discussion between ourselves as physicians, the patients themselves, and management, there's been still a role for those individual patients within the healthcare setting to stay within the workforce. And I think that that's probably the best way forward, is to have an open dialogue, and for most of us, probably to talk to management as well, so that there's more of a sort of understanding throughout a healthcare system.
And I want to bring in Dean Tripp, and just for everyone on the audience, this webinar has a 6-panel limit, so I'm actually going to remove myself.
I just removed myself.
I will be a ghost in the background, but Dean, if you could, when you kind of come onto the screen, I just wanted to get your sense as a psychologist. You've got a healthcare worker who is balancing kind of her or his profession against their personal safety, and I just wanted to get a sense from you is how do you address that balance? I think you're muted.
There we go. I think I'm live now. That's a really interesting question, because in Kingston I have friends in the healthcare system, nurses, etc., and I know people who are at risk physically, and they're in situations that are uncomfortable. As we heard from the panel, you know, a lot of things that go on in regards to the threat that people perceive and the interpersonal kind of experience with that kind of moral courage that's involved with that. And for some people, the response is just, this is how I would behave, and I'm just going to go. There's not a lot of emotion involved with it. And sometimes those people throw caution to the wind, and that's a decision they come up with. But for the most part, people are pretty conscious now of the risks that they are, you know, to others around them as well as themselves. And that's something that's weighing on people more than the individual risk of the health provider, in my experiences. So people are trying to reconcile that with information. And, you know, that's the big thing right now compared to our first time we were on the webinar. And of course, like you pointed out, week by week, as more information becomes available, I think as we are able to gauge risk and also have experiences in being confident that you're able to produce the behaviors that will help keep you safe, that promotes, proactive behavior into these situations. If you're not confident and you're fearful, those types of things can create not only anxieties and fears, but also distances in regards to those behaviors. So people are going to be less likely to engage in those jobs comfortably or at all if they don't feel they have a sense of control in what they're able to do. And that's probably the key point, control.
That's great. Thank you, Dean. There's another couple questions here that I'm looking at on the topic of vaccines. So maybe I'll aim this towards Lisa again. So these are from Beverly and Anna, two related questions. One is, are other vaccines protective against COVID-19, such as those used for pneumonia or flu strains? We always advocate vaccines for our IBD patients. Do those help at all? And as a follow-up, if a vaccine for COVID is developed, will patients taking immunosuppressants be able to receive the vaccine?
Great questions. So in terms of the vaccines that you take, particularly an anti-pneumococcal or pneumonia vaccine or a flu vaccine, do they directly change what happens if you get COVID-19 or protect you from getting it? The answer is not. Biologically or immunologically speaking, they don't, but they will keep you from getting co-infections with influenza and COVID-19 or influenza and hopefully pneumococcal disease. And I can tell you, at least from the outcomes that we've seen so far, co-infections with those two things, either pneumococcal, a bacteria, and COVID-19, or influenza and COVID-19 together, that does not go well. So your vaccines are protecting you from getting very bad disease, particularly if you get COVID-19 with one of those other things. So are they worth getting? Absolutely. Are they going to directly protect you? No, but if you do get them, it will keep you from having very bad disease in the case of a co-infection. New vaccines are being developed. There's been some race to the phase 1 that's almost unprecedented, in fact, in terms of the turnaround. And there are several vaccines that are under development for first in human studies at the moment. There's at least 3 that are being trialed in Canada at the moment. A couple of them, one of them is a DNA technology. One of them, or an RNA, nucleic acid kind of technology. One of them is an adenovirus, a modified adenovirus that is a live vaccine. And there's another one with a different platform that's being developed as well. And there are others that are screaming up to the phase 1 sort of testing line. The key thing to answer your question is whether or not the vaccine is a live vaccine or not. And if it is a live vaccine, once it becomes available, there may well be some stipulations around whether or not it can be administered when someone is on certain types of biologics. If it's not a live vaccine, chances are that it will be something you can take, but there are also new classes out there like these mRNA and DNA vaccines that we're not quite sure where they sit yet, but may be okay. So, and there is some trials of giving people old vaccines like BCG, and we don't know if those are going to be useful at this point either. But that's a great question, and hopefully we will have some choices in vaccines that will allow both live and non-live options for people on immunosuppressants in about a year.
So Eric, if I may, just to pick up on one thing that I think may be important for our patients that Lisa mentioned, and it's more of a operational type thing, is that I think most of us do recommend sort of those vaccines such as the pneumococcal vaccine and the annual influenza vaccine for our patients, and there's not 100% uptake in those vaccines. But I think that one of the calls to action here really with the pandemic is, especially if we think we're going to come down the other side of the curve and we may have a window before maybe a second peak or a second surge in the fall, I would really encourage all the patients that are on the line right now, maybe not now during the pandemic because it would be difficult to get vaccinated, but certainly there'll be a window of opportunity that you should probably go to your healthcare provider and get those vaccines up to date. I don't know if Lisa agrees with that.
I think absolutely. I am the biggest fan of getting everybody vaccinated. Right now, however, the flu season is starting to dwindle, hasn't gone away entirely. So just be, the same things that will keep you safe from COVID disease will keep you from other respiratory viruses as well, hopefully. So just a word to the wise on that one. You may be protecting yourself from other viruses at the same time by our physical distancing and cleaning. I guess the one thing I would say, because flu is on the downswing, and because we are asking people not to congregate or spend expanded amounts of time in public spaces, right now for the next 2 months might not be the time to go get your vaccine unless you already have a trip planned to a physician. That's an absolute must. Otherwise, I would wait for that 2 months on the other side of this peak, which we are going to see, and it's going to come. It's just going to take a little while. And then if you haven't had your vaccines, I'd be running out to get mine, because we are going to see this come and go a little bit with some other minor waves after, and you're going to want to be protected.
Great, thank you.
That's great. I'll throw it over to Gil, and I'll turn off my webcam for you, Gil.
So actually, I'm going to have a follow-up question for Remo. So Shane was asking about just some concerns around safety in infusion centers, and I just wanted to get your sense on that. I know that you've been involved with the International Organization for IBD and looking at it not only at a national level, but also at an international level around infusion center safety, and if you could talk a little bit about that.
Yeah, and Gil, you've been involved as well, and certainly we have a task force not only in Canada but internationally, and we're going to review some of those guidelines tomorrow on a global call. But I can say here in Canada, and Gil, again, you've been involved, is that we've had discussions with the vendors of infusion clinics, and in other parts of the world, those infusions may be done in hospitals. And it really comes down to, I think, 3 key areas. One has to do with the patients themselves and pre-screening patients before they get to the infusion clinics. And so if you're a patient that goes to infusion clinic now, what you can expect, if you haven't already had this happen, is a pre-screening call to make sure that you don't have any symptoms that are suggestive of COVID disease. And if you are sick, you'll have a follow-up call and probably have your infusion delayed. Similarly, there will be screening sort of at the door per se, where temperature checks will be done to make sure that you don't have an elevated temperature as a marker of possible subclinical disease without, say, cough and maybe shortness of breath or a sore throat. And so that's on the patient side. And then we're recommending some very, very strict guidance regarding the clinic itself and social distancing and the behaviors of the workers within those clinics, to make sure that not only do they wear or they adhere to proper hand hygiene in between patients, especially in some of these clinics, one nurse may be being taken care of more than one patient, and you just don't want them to go back and forth. So proper hand hygiene in between, making sure that they're taking off their personal protective equipment in between patients, etc. And so I think that these are evolving, but I think that that's one area that we really want to make sure that our patients are safe in. And again, we're working with sort of the providers of these services to make sure that they're up to the highest standards to protect our patients.
And just to follow up on Remo's comment, from a pediatric perspective, I know that some of the social distancing measures within infusion clinics is resulting, for example, in less visitation, obviously, unless you are a parent with a child. And I just wanted you to kind of comment on, what should parents who have children who are going to infusion centers, should there be any concerns, any extra precautions they need to do or consider? Oh, you just have to unmute your.
I think nothing additional. one of the things that one of our nurses is doing is trying to make arrangements for families that are particularly worried to go to sort of the first appointment of the day at the infusion center. But I think the same precautions as Remo was talking about. And as far as I know, the parent is certainly still able to attend with them. And that would be in keeping with all social distancing practices.
Yeah, and I think just one comment. Sorry, go ahead, John.
Well, these infusion clinics are really an essential part of our service, and I think the efforts that you've made, Remo's made, and others have made around the world are really critical to make sure that we can continue to do this. As was mentioned at the beginning, staying on therapy, we think, is really very important to protecting our patients against flare of their disease, which then leaves them more vulnerable to coronavirus infection. So it really is important. And I can speak from my experience interacting with the infusion providers in our area. They're taking this very seriously to make sure that they can continue to operate. And that means protecting their own personnel as well, because they have only a limited number of employees, and it's in their best interest, it's in their patients' best interest to be sure that they adhere to the highest standard and protect not just the patients, but also the people providing care in those clinics. So I'm very optimistic that they'll continue to provide service and that they'll continue to be safe environments for our patients.
Yeah, and the one statement I just wanted to make that's clear so everyone knows is that there are 4 major infusion networks. They're working together collectively to address a lot of these issues. They're also working with each provincial health authority, health government, and every province across the nation has deemed infusion networks an essential service. That means that if there was a provincial, regional, or national lockdown, infusion centers would not stop. They would still be open. Nurses would still be working there. Patients would still be allowed to go there. And Dina, I wonder if I could bring you into this just because, Anne, you mentioned the whole concept of being worried. And I know that in my telemedicine clinics, it's actually one of the big things that I'm talking to my patients about is just their fear about going into these clinics. And I just get a sense, what should people be thinking when it comes to worry around safety?
That's a great question. There's been a lot of discussion in my circles around how people respond to crises and in general, and how people respond in particular to this crisis. And, many people have styles of responses you see under stress. They range from denial to fear to helplessness, just for example. And, just to give you some background, if people are in a state of denial, it tends to mean that they basically don't believe the threat is viable or real or doesn't apply to them. And sometimes when you see people who respond in that way, you might be a bit puzzled by their behavior. People who are in denial tend not to be volatile. They tend to be kind of a bit dismissive of things. But unlike that, if we look at someone who's fearful, people who are fearful are usually less predictable, and they might respond with panic. They might respond in different ways that are surprising to us, whereas someone in denial tends to be pretty obvious on how they're responding. And when I think about fearfulness and responses to fear, I also think about hopelessness. And hopelessness is a response where you'll start to see people they can't accept the threat, and it tends to overwhelm them. And so when we talk about fear or anxiety, really it's easy to call it fear or anxiety, but it could fall into any one of these categories is what I'm trying to say. So when you're talking to people, patients, young people, pediatric adolescents, older adults even, you see a very different response. There was a story just relayed to me today about a woman in her 80s who at a drugstore went over to her friend, and her friend's like, 6 feet. And the other friend just kept walking to her, and she's screaming at her, 6 feet, she's yelling at her, 6 feet. And the other friend just kept on walking over, and she got about 2 feet away from her and said, "What's wrong with you? Why are you yelling at me?" And she said, 6 feet, like, don't you? She said, "My daughter told me it was 2 feet. And there's, so there's misinformation, there's fear, there's a lot of, things that are happening with people. And I mentioned earlier, control is a big factor. So we have to be mindful of you know, how we're trying to intervene on fearfulness, because you want to try to get a sense of why it's there. That's my primary message, that it could be denial, it could be fear. What is it based on, right? You know, sometimes I think we try to over reassure people, and that can be a problem. So people get ambivalent, or they get, you know, a point where they think it's not a problem. You know, people die from this. This is a serious situation, and we've responded seriously to it. And I think people need to not be over reassured that it's going to be easy, but you have to find a balance in that. So I think how people are going to receive that information is important. How you can pick it up in them is important, but it's an individual thing. And I think I would not be quick to jump the blame on people. We're all under stress, and sometimes it just shows up in different ways.
I have a follow-up to that, Dean, that came in last week. I think we should clarify that it is 6 feet. It is not 2 feet. It's 2 meters, right? So 6 feet is the same as 2 meters. So just to be completely clear for everybody. But a question that came up earlier this week was, how do you communicate the importance to people? So you're trying to tell them they need to stay away. Maybe they need to not come over. There can't be any play dates because somebody in the house is immunosuppressed. How do you communicate that in a way to people who may not be receptive?
Well, the simple message for me is to continue to repeat the message in the way that you're afraid of it. I think that has power, and the more that someone hears that, and the more they hear that message, the more they're going to think, oh, okay, there's, you know, maybe that's not one person who said that, that's the 15th person who said that. It's like kind of a collection of you know, you're putting weight on one side of a scale, and sometimes people need more weight than others to be convinced. If you're a hypervigilant person to begin with, I can tell you once, that's dangerous, don't do it. And you're going to be like, oh God, not doing that. If you're a person that's, you know, not that type of individual, and you're on the other end of the spectrum, you might need to hear that 9 times. And I think what's really important from my perspective is we talk about the age risk. And this is something that it doesn't bother me, but it gets me going a little bit, because what I'm seeing is people think that because it's an age-related risk, you hear this, they're now ambivalent to the risk that they are of infecting other people and creating the death of that other person. And one of the things I've been talking to people about is getting people to remind themselves that we're social distancing for somebody else. Like, this isn't for me. I'm social distancing for you. I'm social distancing for your grandmother. I'm social distancing for that lady in the grocery store. I'm social distancing for that child. And when people start to reflect in a way of why their behavior has a social, pro-social component to it, they tend to own it a little easier, as being told, don't do that because you're bad if you do it. Some people fight on that, but I think if we can get around to talking about how we're doing this for other people, we need to remind ourselves of that often. I social distance so my grandmother doesn't get sick and die. This is something I think we need to think about, is we're social distancing for our society, not for ourselves.
And Dean, if I may, I love that message, and I just wanted to tie that message into what we talked about with the infusion clinics and the screening. Is, you know, if you're an IBD patient, for example, and you are having symptoms, you know, on one hand, we're telling you, please don't stop your medication or don't alter your infusion schedules, et cetera. But we don't want you to hide your symptoms and go to an infusion clinic and then end up infecting sort of another patient and or the staff, and that sort of takes things down. Most of these medications that you're on, if you're on an infusion, are, well, those infusion intervals for most patients, you could probably wait 2 weeks beyond your infusion if you were sort of had some symptoms, and you'd still be fine from your disease. So again, remember that when you're answering for yourself in these situations, that you want to be true about your symptoms, and so that you don't actually harm other people.
I agree.
Yeah, that being said, I think there's been quite a few questions about whether frontline workers should delay their medications or stop their medications if they're not symptomatic. And I think the answer that we've repeatedly given is please don't, please continue. Even delaying 2 weeks at this point, we're not at this is going to last a long time. So delaying 2 weeks is not going to be particularly helpful and may actually hurt if we get to that peak that Gil talked about earlier, where if you flare up and the hospitals are overwhelmed, you're going to be in trouble.
Yeah, absolutely.
So do not delay your medications, even if you're frontline staff, even if you're a healthcare worker, even if you're working in a grocery store, please, please.
And I think just to add on to that for one moment, at least in the healthcare worker setting, people do have protective gear and appropriate PPE in place. And coming back from the fear zone to the biology zone for a moment, we know how this virus transmits. We know how we can prevent it from transmitting. Most powerful, physical distancing, but the PPE works pretty darn well when we use it appropriately in frontline workers. And so I think that reminder in the back of our head about how does this transmit? What else am I doing? If I can't do the physical distance, what am I doing? And there's a lot of things that people can do, especially for healthcare workers, that they will be doing to kind of mitigate a little bit of that fear.
And Lisa, if I could also add, there's been several questions around being asymptomatic and transmitting the virus, and at what point are you infectious? And there's been questions also around, for example, the healthcare worker potentially infecting their families. And I just wondered if you could talk a little bit about how people get infected and when they get infected, and what we should be thinking about in that context.
Sure. It is a coronavirus, and it does get into our systems mainly through eyes, nose, and throat. And it doesn't jump. This is a good thing about it. It does not jump. So if it's on your hands and you wash your hands and don't touch your face, easier said than done, I know. But if it's on your hands, you don't touch your face, it's not getting in. So just a brief reminder about that, because it's really hard sometimes not to touch your face, but that's what armpits are for. Start holding on to your armpits for the next little while. But the biology part's important here. Or yeah, the outside. Oh yeah, I never thought of that. I just tuck mine away. Otherwise, I'll touch my face. But that's important because the other way that it really and truly does spread is droplets. So it's not an airborne virus. And there was a report that came out a couple of days ago that I've answered 200 questions on about the 23-foot virus spread. So I'll talk about that at the end because everyone's read it somewhere on Google. Dr. Google has been busy lately. Most of the droplets that get generated by a cough or a sneeze come out of your mouth or your nose, and they are heavy and they drop within 6 feet. And that's why we have this 6-foot distancing rule. It's because the droplets that are generated by regular coughing, talking, sneezing are generated with a power and a heaviness that usually has them drop out with those droplets that contain virus within 6 feet. So that means that if you're not within 6 feet of people and you're not coughing and sneezing, it's not easy to spread the virus. Could you have virus in the back of your throat that's sitting there that you don't know about before you get symptoms? Yes. We think it's often very low amounts of virus, at least for most of that period. And also, you're not, if you're asymptomatic by definition, generating those frequent coughs and sneezes that actually spread the virus. So are you completely asymptomatic? Probably not. Are you the most infectious person going? Definitely not. And if you're maintaining all the other good stuff and everyone around you is, even if you're that asymptomatic human, it's very hard for you to infect someone else if people are 6 feet away, they're washing their hands, washing high-touch surfaces, and not touching their face. So that's the asymptomatic human being part. And that 23-foot thing, if you work really hard, if you're generating a ton of massive coughs in a really big person, apparently you can get a few droplets that'll go 23 or 24 feet. Could happen on occasion, but clearly it's not happening frequently or with high efficiency, or else this would be a virus that would be spreading much more quickly when people are within 2 meters, and it does not. So could it potentially happen? Maybe. But my bigger thing is, whoever that human is who's generating those massive coughs that send their droplets 23 feet should be staying the heck at home, and they should be out around other people. So 23 feet maybe, but I'm not too excited about that.
And the one thing to add, all these webinars are videotaped, so people can go back and see how many times any one of us has touched our face through the course of the webinar.
I watched myself do this earlier. And what you can't see is that I have a massive container of hand sanitizer right next to me. Now my hands are going back under my arms.
We're getting close to the end, and Rima, I just wanted to ask you a very specific Alberta-specific question. There was actually a question from the audience about access to Humira, and I just wanted to get a sense, if you wouldn't mind, for any Alberta residents watching, just to get a sense of if you had a new start of Humira. There have been some challenges, but those are being rectified. If you don't mind just sharing with the audience.
Yeah, I mean, I think that today in Alberta, through some advocacy work that's been done, when we had the Alberta biosimilar switch policy, not only did the switch from Remicade to either Inflectra or Renflexis happen, but the government took the opportunity at that time to tier some of the drugs that we have available to us. And one of those that was affected is Humira in Crohn's disease was put in a tier 2 bucket, which really left us in patients, for example, with new starts only with intravenous options. So in tier 1 was intravenous Inflectra or Renflexis, and intravenous Entyvio, as the brand names are. You know, again, through some advocacy work, we got good news today that during the pandemic, because obviously it would be nice to have a sub-Q option so patients didn't have to go to the infusion clinic. Humira is now in a tier 1 bucket, at least during the pandemic, and perhaps beyond that. So in our patients with Crohn's disease who are either newly diagnosed or flaring and you need to think about starting therapy, now we do have Humira as an option. And I think that took a lot of leadership by Alberta Health to make that and to help our patients. And so we thank them for sort of coming to the table and making that decision and allowing that option for patients.
Yeah. And the only thing I would add to that is a general comment, and not just specific to IBD, is that there are governments all across the nation right now that are making so many different accommodations, bending so many different rules, going in completely different directions to try to address all of the challenges that we're facing with this pandemic. And in the last few minutes that we have, and I think it's okay if we run a little bit over time, I just wanted to give every panelist an opportunity if there was anything else that you wanted to share with the audience that you felt was an important comment to make. You know, anyone who wants to start can go ahead.
I might say something, Gil. I think one of the great, we're an example of this tonight, using great technology to hold a panel discussion. And all of us have seen these changes in our own practice. And in Ontario, for sure, it's transformed how we're managing patients in the last few weeks. I know that's happening across Canada. And I just want patients to know that our worry, I think, is that our emergency rooms have become extraordinarily empty of anything except for COVID. And we really worry that patients with IBD are managing themselves, fearful of contacting the healthcare system, fearful of coming to the hospital or the clinic. And I think it's an important message that all of us have adapted to new technology, and many of the provincial governments have facilitated this in terms of video consultation, telephone consultation. So we're available through those means, and every clinic is available. And I just don't want patients to feel fearful of healthcare contact in this pandemic, and know that they can reach out to their nurse, their physician, probably more easily than they could a few months ago, because we have new channels available. So I think that's important for people to know.
Any other final words?
I just think for myself, I want to emphasize the point again of you know, why we're doing this, who we're doing it for. I think that's a real important thing. And I know, you know, we can sometimes not feel a risk to ourselves or take a risk because we think it's ours to take. But when you put the emphasis on, you know, like I said, your grandmother, someone else's grandmother, someone else's mother, or you know, someone else that you know that is in a risk category, I think we start to turn ourselves a little bit more towards the behavior we want. So just think about other people. You know, Canadians are pretty good at that. So I think it's a good example for us to flex those muscles like that.
I guess the only thing that I would add, and hopefully, I think Dean has talked about this if you were on sort of previous WebExes, is to John's point, we always want to take care of the physical part of your disease, and I think most physicians across the country are here for you for that. But there is a lot of stress and anxiety associated with this time, and I think it's really, really important for the patients to do things that take care of their mental health as well. Not only because of the stress of the time we're in, but the fact that, you know, we're isolated, or more isolated, and we're social distancing. So it's okay to have some stress and anxiety. It's okay to be fearful, but, you know, just self-reflect and be able to, there's a lot of online tools that can help you through this. And so I would encourage people to reach out for those tools just to help them cope through this from a mental aspect.
Well said.
One quick thing, thank you. I've been around a lot of Canadians lately who are doing a great job of staying home, and it's not actually easy. It's a new job we've all got as Canadians, staying home and staying physically distanced. And I just want, as an infectious disease person who's watching some of these curves start to flatten a little bit, to say thank you and keep on with it. Because this is a marathon. It's a new job we all have, and I'd just like to say thank you to everyone who's out there and doing that, and obviously engaged enough to be on a webinar like this in the evening. You're the converted, so spread the word and keep people at their new jobs.
And Anne, any final word? Oh, you're muted as well. There you go.
Echo what John said, and that is that for our pediatric patients, I think we've been able to convert to video conferencing for visits very well, and that's what's happening all the time. And a shout out to our IBD nurses as well at Sick Kids, who I think are taking more than ever numbers and of calls, and I'm sure that's helping a lot.
Absolutely, I echo that. The nurses have been instrumental in us making this transition, so thank you all. And I'd like to thank all the panelists for volunteering their time, really spending their evenings doing this. I think it's been really informative. I've learned something, and I'm sure the audience has as well. I want to close by saying that this webinar and all the activities of Crohn's and Colitis Canada wouldn't be possible without the staff and the volunteers, including the physicians answering your questions tonight, physicians and healthcare providers. These vital Crohn's and Colitis Canada activities and staff are paid for by your donations. Unfortunately, due to the coronavirus pandemic, Crohn's and Colitis Canada has had to cancel all in-person fundraising activities. And you heard about the Gutsy Walk changing and evolving today. And so, you know, we're all very concerned that nonprofits in Canada, including Crohn's and Colitis Canada, may have a very difficult time providing the services that they've been able to provide to you before. We just got word earlier today that to CIHR, the Canadian Institutes of Health Research, which is the #1 funder of IBD research in Canada, with Crohn's and Colitis Canada being #2, CIHR actually canceled their spring competition, and so there will be no funding for new research in the spring, and it's been delayed to the fall. We all understand that obviously our economy and our entire being has changed and is evolving and is unfortunately under great stress. But it's my plea today that if you can afford it, please, if you can log on to crohnsandcolitis.ca, et en français c'est crohnesetcolit.ca, And please donate to Crohn's and Colitis Canada so that they can continue to fund educational webinars like this and the staff that help put this together, as well as the vital research to find a cure for Crohn's and colitis and improve the lives of patients and families living with IBD in Canada. So please, please, if you have the funds to do so, please log on to the website and donate whatever you can. Anything will help. Anything will help keep the labs doing research in the disease going. Anything will help with the educational activities that we're providing to you. And Remo mentioned earlier the advocacy work that was being done. Crohn's and Colitis Canada played a huge role in that as well, in trying to advocate to BC, Alberta, Ontario regarding the mandatory switch policies, and with that in Alberta, the tiered policies. So I think that we played a big role in changing that policy during the pandemic. So all of that can't be done without your donations. So please go online, crohnsandcolitis.ca, crohnecolit.ca, and donate to Crohn's and Colitis Canada. And I'll leave it to Gil to say goodbye. Oh, you're muted, Gil.
Sorry, I just wanted to end by thanking all the healthcare heroes out there who are on the front lines working today, yesterday, and tomorrow. For those who came a bit late, I explained that I'm in my scrubs today because I've been on call this past week, and being on call at Foothills Hospital, I've had a number of conversations with colleagues of mine in hallways and in wards, and we're all afraid and we're all nervous. Personal note, I have asthma. I've had lung collapses on both my lungs. I don't know what would happen if I got COVID. I think analogous to how so many patients with IBD who are immunocompromised are afraid as well. Talking to my colleagues, I've heard so many different stories from them as well. And we're there on the front lines, and we're putting our lives at risk. We're doing everything we can to protect ourselves and our patients. And I just wanted to thank them immensely every week. And every week we're going to be here answering your questions, giving you updates, helping you through this pandemic. Thank you.
And I should mention, Gil, one more thing I forgot to mention is that we got to as many questions as we could today. There were lots more questions, unfortunately, we didn't get to. I'm really sorry. We did our best. But we are putting together a frequently asked questions, an FAQ page that hopefully will answer most of the questions that we couldn't get to today. In addition, we'll try to answer further questions in future webinars. So thanks for your patience if you didn't have your question answered, but it will hopefully be answered on a page soon. And thank you, everybody.